will be available on the council's website later, so other people can still catch up. We have also got a special group of people here today. I believe we've got postgraduate students from the Leeds Beckett University, and they're here with their lecturer in politics. Can we see your hands? Yeah, can you all wave to them and say welcome? Okay, good to see you all. Do I take it you're also students in politics, is that correct? Oh, public policy, excellent, wonderful course. Well, I hope you enjoy our meeting today. Right, so I will start with introductions, and I will start with yourself, Councillor J.
Councillor James Gibson, Crossgates and Winmore Ward.
Councillor Mohammed Iqbal, City Consulate Riverside. It keeps changing names, so yeah.
Councillor Eileen Taylor, Chapel Allerton Ward.
Good afternoon, John Beale. I'm Chair of Health Watch Leeds, and I'm a co-option member of this board.
Luke Farley, Labour Councillor for Bermondsey and Richmond Hill.
Good afternoon, Councillor Eleanor Thompson, Guiseley and Rawdon Ward.
Councillor Sharon Burt, Littleton Park Ward.
Sorry, I was hesitating because I'm not actually a member of the board. I'm Councillor Fiona Benner. I'm the Cabinet Member for Children and Adult Social Care and Health Partnerships.
Hi, I'm Councillor Salma Arif. I'm the Executive Member for Public Health and Active Lifestyles. Thank you.
Hi everyone, I'm Victoria Eaton, Director of Public Health at Leeds City Council.
Hi everyone, I'm Rebecca Cholworth, and I'm the Independent Chair of the Leeds Committee of the West Yorkshire Integrated Care Board.
Hi everyone, my name is Tim Riley. I'm the West Yorkshire ICB Place Lead for Leeds, which I always find very hard to say.
Councillor Winkage, representing Morley South.
Councillor Conrad Hartbrook, representing Rothwell Ward.
Good afternoon, everyone. I'm Councillor Caroline Anderson. I represent Adlon Wharfdale Ward.
Good afternoon, Councillor Norma Harrington, Wetherby Ward.
Afternoon, everyone. Rob Clayton, Scrutiny Advisor to the board, standing in for my colleague Angela today.
Good afternoon, Toby Russell, and I'm clerk to today's board meeting.
Thank you very much, board members and all our partners here today, exec members, as well as directors of the different services that we have. So you're all very, very welcome. And a special welcome to our former colleague as well. I almost called you councillor again. It's hard not calling you that, Rebecca Charwood. So it's great to see you and welcome back to council. So thank you all for coming, and to the rest of you out there, thank you very much for joining us. Okay, I will now call on Toby to take us through agenda items 1 to 5.
Thank you, Chair. Under agenda item number 1, there are no appeals against the refusal of inspection of documents. Under agenda item 2, there is no exempt information that will require the possible exclusion of the press or the public. Under item 3, there's no late items noted. Under item number 4, can I ask members to declare any interest they may have? Take that as none. And under item number 5, there have been no apologies for absence received. Thank you, Chair.
Thank you very much, Toby. Okay, agenda item number 6, our minutes of the last meeting, which was held on the 20th of September. Asking if anybody has got anything to say and to approve that it's a correct records of the minutes. Is that a yes? Can I see a smile and a nod? Thank you, members. Excellent. All right, agenda item number 7, local ICB arrangement updates. And thank you to all the partners who are here. So in accordance with the Health and Care Act of 2022, Integrated Care Board's ICB took on the commissioning responsibilities of clinical commissioning groups from 1st of July 2022, as well as being tasked with leading the integration of health and care services across their area. So following the work undertaken last year, this scrutiny board agreed to maintain a watching brief on the evolving local ICB arrangements, and today's meeting provides an opportunity for the scrutiny board to consider the latest position and to just hear from them. It's really great to see you all today, and I have actually been looking forward to this because we are keen to hear updates about what you've been doing and where we all are going with the ICB. So you have already introduced yourself, so I don't need to tell you to do that. I'll just ask the exec members if any one of you would like to say anything first before I invite team.
This is the health and wellbeing refresh, isn't it? Yeah. Yes, I'll make some introductory comments and so will Councillor Arish. Thank you. So so the current health and wellbeing strategy was initially from 2016 to 2021, and it was extended to 2023. Obviously, in the last couple of years, we've had other things to attend to rather than updating the health and wellbeing strategy. So we're now looking at developing the health and wellbeing strategy. Sorry. I think it's the ICB. Sorry, I'm on the wrong item. I do apologise, Chair. Sorry, I thought
I was wondering what was going on there.
Yes,
right.
No,
okay.
I was going to. I apologise.
That's fine. Don't worry. We're very kind in this board. We'll let you off.
No, it's fine. I didn't have the papers open in front of me. I looked at Councillor Aris over her shoulder and misread what she was reading. Okay, so the integrated care board. So the Act came into being on the 1st of July, and as members will know, there was a report that went through General Purposes Committee and then to full council, outlining the changes that this meant for the council constitution, which was a bit of a bureaucratic process we had to go to because the changes were really pretty much just replacing the words clinical commissioner group with Leeds place-based committee of the integrated care board. But we've been through that process. And the report today is providing you with your regular updates that you've had periodically as we've been going through this process of the development of the West Yorkshire Integrated Care System and the Leeds Place-Based Committee of the Integrated Care Board. And it's really wonderful to have Rebecca with us today, who's the chair of the Leeds Place-Based Committee of the ICB. And from our perspective in the council, it's really great to have somebody on that board who has not only a really good understanding of health and care systems, but specifically a good understanding of local government and the council's role in delivering health and care. Rebecca also sits on the Health and Wellbeing Board, and I think I've mentioned before at this meeting that in the legislation there's no formal link between health and wellbeing boards and place-based committees, which is generally, I think, seen as a weakness in the legislation, and it's been discussed in a number of meetings that I've been in. So I sit on the board of Leeds and York Partnership Foundation Trust, and we had a council of governors meeting recently where we were discussing this, that it is generally seen as a weakness that there's not a formal link in the legislation. However, the links are strong in West Yorkshire and in Leeds. So if you look at all the kind of diagrams of the new system, it's really clear that in all 5 places in West Yorkshire, we are seeing the role of the Health and Wellbeing Board as very important in setting the strategy, which the place-based committees will then deliver. And all the key players in health and social care in Leeds sit on the Health and Wellbeing Board. So that includes all the chief execs of all the trusts, and Kath Roth as the director for adult social care in Victoria, as director for public health. And there's people from, Health Watch and the third sector. So it's a really representative board, and will have a key role in delivering the health and wellbeing strategy, which we'll come on to talk about later. At the same time that we're refreshing our strategy in Leeds, the West Yorkshire strategy is being refreshed as well, but we'll talk about that more when we come on to that item. But they're just my introductory comments, Chair, on the integrated care system. Thank you.
Thank you very much, Councillor Venner. Okay, team, I believe you'll be leading on this presentation. Is that correct? Yeah, over to you.
Thank you. And thanks for the opportunity to come and speak about where we're up to. And I'm really delighted to have Rebecca here as well. And as the chair of the Leeds committee of the ICB. I don't want to say a huge amount. You've had the paper before you. A few things I'd just like to pick up on, which Councillor Venn has just mentioned the refresh of the West Yorkshire strategy. That's a requirement nationally that every ICB has a strategy in place by the end of this year. West Yorkshire's had one for a long time already, and what we see this is primarily an opportunity for a review and a refresh rather than something brand new. That's positive for two reasons. One, it shows a continuity and a commitment to long-term change and improvement across West Yorkshire, including in Leeds. And secondly, I think really importantly, that because that initial strategy was created before ICBs were a statutory function, it was done with consent and in a partnership space. So I think that continuity is really important because it shows the continued desire of West Yorkshire to operate in that kind of way. It is a very inclusive development approach, absolutely aligning to things like the Health and Wellbeing Board strategy refresh, and a genuine desire. And a number of people from Leeds are working in that space with colleagues from other parts of West Yorkshire to develop that. And indeed, I can't stay for the rest of the meeting because that's where I'm going next to the West Yorkshire ICB board development session, which is looking at that strategy. So that is one really important connection. We want to both influence what is said at West Yorkshire in so that when West Yorkshire sets out its strategy, it is those things that we want to deliver and really matter to us as a city. Second thing I wanted just to touch on is the Leeds ICB arrangements. That's the committee itself and its subcommittees and the sort of connections and governance. And we mentioned the link to the Health and Wellbeing Board. Those things are all in place. The committee has now met a couple of times and had a development session. And also the subcommittees are meeting and all the positions are appointed to within that. I think really importantly, there are independent voices as well as Rebecca as chair. We have three, and John from Health Watch is also on that committee. We do have two other independent voices as well, Yasmin Khan and Cheryl Hobson, who pick up particular leadership roles, one around sort of delivery and health inequalities, and the other around financial investment and good governance and so on. So really two really key roles, and Rebecca picks up around quality and safety and patient voice. So that is important. It's also important, and I think this is a difference from CCGs. There are some aspects that are the same and some aspects are a carry forward. What is really different and really positive is not only the partnership of with our local NHS providers. So we have them in the room helping make decisions collectively, but also colleagues, so Kath Roth and Victoria sit on that committee as representative officers of the council. So I think that is a really positive step forward. I'm not always the greatest fan of changes in legislation, but that element of change in legislation I'm really supportive of, and is already beginning to bear fruit. So I'm pleased about that. The third thing that you'll see in the paper, this has been developing over a time in Leeds. We've had a whole range of boards of various types looking together in partnership at a range of things, whether that's mental health, end of life, long-term conditions, significant number of those. And that has been really useful in helping us develop strategy in a joint way. As we've been going through this process, and not a requirement of changes in legislation, but really important, we thought, in terms of good governance and developing our system in a truly integrated and partnership way in Leeds, is that those boards are in the process of evolving, being given more responsibility, not just for strategy development, but for delivery, and also understanding and managing some of the financial, at least creating recommendations to the wider board. So taking a very distributive leadership model. I believe that's important, particularly for a city the size of Leeds, and has put us in good stead. In many ways, when West Yorkshire looks at things, it knows where to come in Leeds, because Leeds have got a really good handle on whether it's children or mental health or wherever. So we did want to highlight that, and those are linked in through the executive team that works as partners across Leeds through into the committee of the ICB, and then through the links we've discussed, and Councillor Venner was talking about just now, to the Health and Wellbeing Board strategy. Obviously, it's still quite early days. There are big agendas that we're going to have to wrestle with, as indeed I know colleagues in the council are, around sort of the finances as we head into next year, and from an NHS perspective, and how we align that particularly to adult and children's social care and public health, but more broadly. So that's one of our sort of challenges that is a particular responsibility of that committee. But we are also looking and making very clear and that the patient voice, the public voice, the people's voice is right at the heart of our decision making. And we've sort of made that a standing item right at the start of all our meetings, to consider in one form or another, particularly with the support of Health Watch, what the public is saying about the services they receive from the NHS and social care across the city. I'm really interested in, I'm sort of half of me hoping you haven't noticed much difference, because it should be smooth and seamless. Another part of me hopes that in time that you will begin to see a difference as that integration agenda improves, but develops really. I am interested if there are any observations that you've had of how those things have gone, as well as ours. So I'll stop there. I don't know, Rebecca, if you want to add anything, very welcome to.
Thanks, Chair. And thank you for inviting me. It's really good to be here. Nice to be in the Civic Hall again. So I'm in a very new role, independently chairing the partnership, and it's a role which is about facilitating the partnership in the meetings. It's 2 days a month, so it's very different to the former chair of the CCG which was a statutory organisation. The statutory organisation part is now at West Yorkshire, and Cathy Elliott chairs that. So I am an independent chair. So I suppose I'm providing that facilitation role, but then also hopefully a knowledge of and deep understanding, hopefully, of all the different institutions and ways that we've worked together in the past, and perhaps opportunities of how we can work together in the future, and providing that external challenge to the board itself. And my view about the essential sort of new thing is that whereas before the clinical commissioning group was about commissioning the services and then buying those services, competition was a big part of that in the legislation. The new arrangements are moving towards a more collaborative approach of commissioning as a city together. So I'm not a commissioner. I facilitate a partnership which commissions for the city itself, and that includes all the partners in the NHS, and has attendance from council as well. So I just think the more we do together and the more we can align what we do, the greater the benefits for the population and the services that we can provide. And that goes with the local authority services as well. If we can align more what we do, we should get better outcomes for our population. And as we know, there's always pressure on public sector finances. So the more we can do together, hopefully the better we can protect the things that we really want to do. And working on health inequality is the central role to that. And I know that members here really care about that. So I'm delighted to be here. Lovely to see you. Thank you for having me.
Thank you very much, Rebecca. And like I said earlier, great to have you. Thank you, team, for that presentation. I know towards the end you did say you hope there's no difference. One thing I am certain about, the common man out there, they don't really bother about whether it's called ICS, whether it's called ICB, or it's called CCG. All people want to know is that we are working towards narrowing that inequality gap and making sure that we're delivering the services that we say we will deliver. So I will now open up to members if you have any questions for Tim and Rebecca, based on what you've heard and based on the paper in front of you. Bearing in mind they're coming back in March as well, because obviously that would have been good enough time for them to, to have been into the post that they all are in now, and will be able to give us a more detailed feedback and update on what they have been doing. But if there's any question or any comments you would like to make, please feel free to do so. Yes, Dr. Bill.
Thanks, Chair. I'd just like to pick up the point made by Councillor Venner, because I would agree with her that that sort of non-direct involvement with local authorities, I think, is somewhat surprising, actually, because the Integrated Care Board is part of the whole concept of integrated care partnerships. Actually, the NHS and local authorities working together, health and social care working together, and it is somewhat surprising. However, we were already basically there before the Act was passed. And Tim's quite right. In one way, you won't notice the difference because we've already been doing it for several years in Leeds and indeed in much of West Yorkshire. And for instance, the changes which you probably will see, the establishment of the population care boards, would have happened, I'm quite sure, irrespective of the legislation. It's not because of the legislation, it's because Leeds was already going down that pathway. And when you look at the members of the Leeds committee, for instance, the Director of Public Health was not a mandatory post. We chose in Leeds to have the Director of Public Health as part of the committee, but we didn't have to, and it clearly fitted the way which Leeds wanted to work. So, yeah, I think irrespective of the legislation, we are building on what already existed and was already developing in this city.
Absolutely, Dr. Bill. Thank you very much. Yes, Councillor Venner.
Yeah, just to add to that, in terms of local authority representation, we have that at West Yorkshire level. It's Tom, our Chief Exec, who is the local authority rep at West Yorkshire level. And then we have council representation, as has been outlined, on the West Yorkshire Place-Based Committee. We always have. There's also a layer between the West Yorkshire board and the Leeds board, which is called the West Yorkshire Partnership Board. And I sit on that, and so does James Lewis, our leader, and our equivalents in the other authorities. And that's chaired by Councillor Tim Swift, who's the leader of Caldesdale. And as Dr. Beale said, that we were already ahead of where we needed to be, and that we've had that partnership board for a number of years. So we've had that strong partnership working across West Yorkshire, and that strong involvement by local authorities. But I think the point that Dr. Beale made, it relates to a wider point as well that I've referred to here before, that there are some aspects of the legislation that are quite concerning. You know, one of them is the not having a formal link between health and wellbeing boards and the place-based committees. There's also there's increased powers for the Secretary of State should they choose to use them. The one I was always lobbied on as a Labour councillor was the fact that private sector organisations can be on partnership boards. We've chosen they won't be in West Yorkshire, but that's a choice that we've made. And I think the point that Dr. Bill finished on, which is irrespective of the legislation, we are moving forward, would be my take on the whole thing, really, that irrespective of some of the challenges in the legislation, some things I would see as problematic, we have really good relationships across West Yorkshire. People are really committed to services being delivered at place, so the kind of threat of regionalisation is minimised. But it does feel as though the strong relationships we've got and our commitment to the way we work together is mitigating against what could be problematic within the legislation. Thank you.
Thank you very much, Councillor Venner. Yes.
Just a very quick question. Well, how is the Constitution came to scrutiny, and I think we're all pretty happy with it, if memory serves. How is it reviewed? Is there a process for reviewing the Constitution? Can it be changed? I know that I suspect, I don't know if you've seen it, but the British Medical Association have been quite critical of some of the ICB's constitutions. I suspect that that won't include West Yorkshire's, actually, from what I'm reading at the moment. Things like, well, for example, that only 2 ICBs guarantee voting positions for public health specialists. Well, we've already said that we do in West Yorkshire. So I think we're the exception to the rule. But presumably there'll be pressure from trade unions and other interest groups like the British Medical Association to review some of the constitutions. And I'm just curious as to is there a process for that? Because we seem quite happy with our constitution. We don't want it to change. So
So yes, there is a process. The process would be led not from a national end. It would be led by the ICB concerned. So at any point we wanted to change it, we would be allowed to change it. We would have to demonstrate we'd consulted widely on any changes that we were proposing, just as we did with the original, and then we would effectively recommend from the ICB board to NHS England any changes. Our intent is 12 months in to do a review that may or may not lead to any changes, but we felt it was right and proper, given this is new legislation, a new format. We ought to at least give ourselves that responsibility, I suppose, to review. But that's the basic basis, and any ICB can do that. I think we are unusual, not just in terms of the public health, but we also got GP representation, and neither of those were initially in the legislation. And I suppose we've lobbied quite hard on some of the legislation and have had some impact, but there are still areas where I suppose we could be concerned, and we ought to keep a watch. One of the areas, if I can just pick up on Councillor Fenner's last comment there, I think we've done really well to date in the sort of primacy of place, the dangers of sort of regionalisation of decision making and so on. That is much more to me about behaviours and process rather than it is the constitution and the legislation. So I think I would say we need to remain quite vigilant around that. I don't think that those will go away, not least because NHS England doesn't see the world quite like that. It recently released last week its operating model, and it's very clear it sees ICB/ICS as the regional level that it will work to. And therefore there are some challenges around that going forward. So I would just say we need to remain vigilant on that. The constitution's fine, but it's about the behaviours and processes that sit around that.
Thank you, Tim. Councillor Hatbrook.
Thank you, Chair. It seems clear that Leeds is starting from a good position in forming this. And I think picking up on the Chair's comments that for some this will see, it's a technical change, and what people care around is what is, what in terms of the care offering or tangible changes that they can put, can be pointed at, will be delivered. Now, again, the group's being formed. It's been formed from what feels like an evolution in Leeds, because it was similar to what we were doing already, which is a great place to start from, but it is still forming. So once we get into kind of the norming and the storming stage, what if we're sat together in March or 6 months' time or so, what kind of things should we be saying? Actually, here are some of the things that hopefully you've already start to identify some of the things that, do you know what, these are the priorities for programs of work. These are the changes where we think we can harvest synergies and get the best out of things, just so that we've got something to hold the feet to the fire from in 6 months' time to say what we've done on it.
There are three things that I just jotted down that we've already discussed where I do believe there are some important changes, synergies, and when you see the plans for Leeds and how the NHS budget and so on has been agreed, given the challenges we face, that I would be expecting you to ask about, or for opportunities as well. Clearly, one of them is around primary care and access to general practice. That remains hugely challenging, not because we've not invested in increased capacity. There's more capacity, but that is not feeding through, and we know it's not feeding through in terms of experience. And that was one of the important conversations we had coming out of Health Watch's a report from Health Watch that we discussed at one of our earlier meetings. And I think what's different now is that's very much a partnership owned issue rather than a very sort of almost in a corner of a CCG, which is how it was before. It is delegated to us. It is our responsibility. So that is one area. And also, there will be some questions about other aspects of primary care, including dentistry and optometry going forward, how West Yorkshire decides to take on those responsibilities and delegate them or not is still to be worked through. I think the other area you'd expect us to be talking about at the moment is winter pressures. But we're beyond that. We are in the process of working to really review the whole intermediate tier of services in Leeds, that mixture of home-based and bed-based care that either can prevent people going into hospital unnecessarily or aid their discharge and reablement coming out. That's a major piece of work, and we're in the sort of we've got ongoing pieces of work that we need to do, make sure that we're in as good a position as possible for winter, and it's hugely challenging even as today. But also we've got a more medium-term piece of work where we've been with the diagnostics underway and will be completed in November, and from that will come a plan. And there are really big synergies there, I think, particularly with adult social care. The other areas around health inequalities, many of you will know NHS England have launched this 5+20. That might be wrong. I'm not very good at some of the names that NHS England come up with. But basically, it's making sure that we focus some NHS resources in NHS England world to the 20% most deprived, but given the scale, West Yorkshire's taking the position it's the 10% most deprived parts of our community, but also into a number of, and that's the sort of 5, but into a number of areas where clinical areas that we need to look at, but also not to lose sight of specific communities, people with serious mental illness, for example. And I would, we've already discussed that as a committee. That's come through. Certainly one of the subcommittees, delivery and health inequality subcommittees looked at our plan for this year. I do think going forward, that again is an area we'll need to be really closely aligned to. And you will want to be cited on. So those are my sort of initial thoughts. There are, I think, pieces of work in children's and so on, which there are a number that we can really look at and will be. But those are my initial 3.
Thank you very much, Tim. Councillor Taylor.
Thanks, Chair. I know Leeds is the best city, and we are the best city, and this council are working really hard to provide for each and every one. I'm going to sound a bit cynical here, but it's nothing to do with you personally. If Tim was here, I always get on Tim. And page 12.4 is health and well-being, inclusive good and zero carbon. But further down, it mentioned the poorest health will be better fast. I always have something against that. I know there's a lot of good things happening in public health, especially since Victoria took over. She's doing the best she can, but she only can do so much. And now Rebecca joined her, who was a part of the council. We want to deliver for each and every citizen of Leeds. But when you say the poorest health will better first, I'm not happy with that, because I represent, like many other councillors, deprived areas, and I can't see where the poorest in my community would be seen to, especially today. You can't get an appointment at the doctors and they have to go to challenges. So if we are going to be honest, we have to say the way we are expected to be. But if a poor person approaches a doctor today and a rich person have their money to pay, that rich person health will assist to. I was just talking to Dr. Bill with the dentist. If you have money, you can go to the dentist. If you are poor, you can't go to the dentist. So if a poor person approach you, how are you going to explain that their health will be seen to first?
I think we need to start with acknowledging, the reason we set that ambition is because it's not. So I agree with you in many ways. Really importantly, and this is where I think the link with the Health and Wellbeing Board is so important, is to be really sharp and clear about what it is that the broader city and society needs to be doing. And often that is rightly led by the council and the work that you all do to try and to narrow inequalities, because we know that as a conservative estimate, I think it's probably higher, probably 80 to 85% of someone's health outcomes are driven by those wider determinants, and hence the conversations later about marmot and so on. What is really important from an NHS perspective is that we play our part under your council leadership around those. So I'm thinking of things about the anchor institutions and the way Leeds Teaching Hospital, for example, has worked in its community to try and be a contributor rather than almost completely separate. I always remember a GP in when I worked in Stockport across the other side of the Pennines, challenging a consultant at the world-renowned heart treatment centre at Wythenshawe Hospital, pointing out that Wythenshawe had the poorest heart outcomes of any place in England, despite the fact the hospital in its midst had the very best and was seen as a world-class service. So there's something really important about all our institutions playing that anchor role and getting engaged. And therefore being able to point to, well, actually the way we employ, the way we contract and procure other services and so on are contributing to the wealth of the city and are particularly contributing to those areas that are the least wealth. There is then that 15 to 20%. And I think that's where the health inequalities work, and why we've deliberately set up one of our subcommittees as a committee which is focused on delivery and health inequalities, and chaired by Yasmin Khan, who's works in third sector background and has a real passion for inequality. So are we there yet? No, we're not. I mean, we know we're not. There's a lot of work that needs to be done. I was really pleased. I was just looking at a report from West Yorkshire for the next meeting I've got to go to. And there are a number of areas where some of the things that the NHS ought to be doing, for example, checks on key health issues, where actually we unusually, because not everywhere in West Yorkshire and certainly not everywhere in England, are able to demonstrate that people from our most deprived communities or from very vulnerable communities, such as those with serious mental illness, are either getting the same access to those key secondary prevention pieces of work or better than the population as a whole. We're not yet quite there that it's routine, that it's better, because it should be if we're serious about this statement. But at least compared with most places, we're at the same level or better, or one or two better. So I can't at this stage say for definite we're going to succeed, but I do think we've set up within Leeds as a whole and within the committee and its substructures and our commitment to looking at data at a sort of ward level rather than at just a global Leeds level, the processes by which we might do that. And we remain committed. It's a real commitment of the senior leadership of the NHS. I always smile because Julian Hartley, the chief executive, I'll probably call him Sir Julian Hartley, the chief executive at LTHT, I see him very excited about lots of things, but one of the first things I ever saw him excited about was the anchor work they did as an organisation. That is really unusual for a chief executive of an acute trust. That is not the big thing. So promise, but we're not there yet.
Totally agreed what he says. It is a challenge, but I always go back to third sectors. Third sectors know their community. I'm just coming from third sectors events, and it's Black History Month, and they've got so many different agencies in there doing blood pressure, all different things, and I was really happy. But one lady came to me and she says, "Oh, I've got my blood pressure check and it's high. And my doctor is supposed to have an appointment 2 weeks ago and I didn't get an appointment. Now it's the third sector did it today." And I says to her, "Get in that and don't move. Get them to assess your medication." So these are the things. I don't know if it go by, which I do know it go by postcode, but we need to look after the poorer, vulnerable and put their health first. Else, I don't want to see this in the paper, because a poor person will come to you and says, "You told me my health is going to be first seen to," and it's not happening.
Thank you very much, Councillor Taylor. I'll call you Victoria, just with what you were saying, team, which obviously in terms of your commitment, which is great for us to know and say, but what we would love to see is actually the practicalities of it and the outcome. So obviously we do know that you're scheduled to come back in March. So what will really be good in terms of the impact this has had, because obviously we do know we've got COVID to deal with in terms of the effect of COVID, long COVID, and obviously we now have the cost of living crisis. Can I ask why my microphone is going off and on? Okay. The cost of living crisis as well, which will be hugely impacted in terms of people's health and well-being, as well as their mental health. So it will be good to know where we are in terms of data and statistics. And then when we come back in March to see what we have achieved as well, because that will help and guide us in knowing, they said the journey of 1,000 miles starts with a day's step. So at least we know where we are now. Come March, which is about what, 6 months, 7 months from now, then we can kind of evaluate and see where we're going. It's not going to be a straight turnaround 360. We do know that. But at least if we can start making some progress. From the report, I did read that South Leeds, Hunslet have got one of the highest maternal deaths in the country. That's in our city, you know, and that really hurt me just reading that. So without knowing all of those, what are we doing about it? How are we combating that? So these are the kind of information that we would love to see come March. Obviously, we know it's still new. You're all still developing a lot of strategy, but we would love to see real-time information, data on where you're at come March 2023. Is that my big voice blowing into it? All right, okay. Victoria, please.
Thank you, Chair. So just to briefly add, I know that was a long conversation, but in terms of comment on Councillor Taylor's comments, it does feel like this is the essence of what we want to be, and it does reflect the earlier conversation about us making active choices to join this up, even though we don't have to. We've made active choices to do that, but I think the challenge is right. And certainly in the conversations that we've been having so far in the committee and as leaders across the system, is that we have to continue to put the people of Leeds at the centre of all of our collaborative work, and then come together as the new arrangements take shape to both ensure that those arrangements are absolutely maximising everything we can possibly do that is within our power, but also to connect them so people don't see those joins. So in a sense, I think there's two really important things that it feels that we want to keep track of and be very vigilant about in Leeds. And part of that is about the critical role in terms of health inequalities that the NHS plays. I mean, Tim mentioned the 20%. We understand from all the evidence that it's around, you know, for the things that affect people's health and health inequalities, there's about 20% contribution from the NHS, which obviously is smaller than the 80% that's out with the NHS. But it's still incredibly critical, as you say, that everybody can get access to see a GP or to access the services they need, that those services are culturally appropriate, that they're delivered in the way that would give us the best outcomes for communities. And we know the learning we've had, not just through COVID on all of those things, but pre-COVID as well, about trusted organisations and about working in a way that works with people to give us the best outcomes. So there's a huge commitment to working with NHS colleagues to make sure that we build on all of that work. And I think, as Tim said, it's just keeping an eye on that top-down approach that comes from through the national NHS around the way that they see health inequalities as this 20% plus 5. You know, it's not the way that we would build it up locally. So we have to make that work. So there's something about doing everything we can on that. And then the other really critical thing is making sure that all of that work actually joins up with the 80% of all the other stuff that the rest of the city is doing, including the work that the council leads, to keep people healthy and well in the first place. So I see that it's a big part of my role, but also colleagues' roles, to continue to join that up across the city and not have duplication and silos, because if we're not vigilant, that's what will happen. So I think your challenge is absolutely right, Councillor Taylor. And just to end on, Tim and I have had some really positive conversations about how we use kind of a shared set of ambitions and and headline indicators on progress in terms of those population outcomes. So how are we doing around health inequalities? What are the things we would measure? Making sure that that's a consistent approach across organisations across the city. So I hope that's helpful for now, but more than happy to talk about that in the future.
It's very helpful, Victor. I know we as a council and NHS are doing what we can to help outside. And sometimes some of them need to take responsibility. I'm not fading away from that. But what I'm saying is what you put in black and white to go out to the public, we should accommodate it. We are the one that out on the street campaigning, and we are the one that getting these comments. You know, I can't see my doctor, blah, blah, blah. This is where I'm coming from. Some are very intelligent, although they might in a deprived area, they'll say, well, you have it here in black and white. So why am I not having it? And this is what I'm saying. We don't promise and don't deliver. You know, but I do know that there's work going on behind the scene. Rebecca did a good job when she was exec, so is Fiona. They are still doing a good job working alongside you. I'm not going to praise NHS all the way, for since pandemic, I think they have slipped away, to be honest to you. No fault of the NHS is coming from central government, but it's a lot of work to be done. So we have to educate the public and give what we promise. Don't let them keep chasing for it. That's what I'm saying.
Thank you, Councillor Taylor. Rebecca.
Thank you. Thanks, Chair. Thank you for that discussion. And it's really lovely to see colleagues again and hear familiar arguments being made, which we all agree with. Just reflections on what that I've got from my time when I was in the Health and Wellbeing Board chair role and this role now is, and during COVID and following that as well. When pressure is exerted on the system, when there is difficulties and system pressures or COVID or whatever those pressures are, the national priorities and the political priorities, as an independent person, my reflections are that it's ambulance, it's A&E waiting times and it's GP access that get an acute sector that the pressure to fund that work ranks up higher and quicker than any other pressure. And in times of great demand and great pressure, like during COVID and following that, issues that we know are really difficult for our city around mental health, access, health inequalities, are further down the priority list in a national way, with the press and in my reflections on. And so what we have to do locally, and what we have done when I was in the council and now, is have plans that prioritise our local action to those long-term priorities about health inequalities. And that's why you see plans such as that tie our partners in to a vision that we have together of health of the poorest the fastest and improving that. And then what we can do locally is refer back to that all the time about this is our plan, regardless of the headwinds and the pressures that exist, which they do. And we have to meet those pressures, but we also have this, which we've agreed to. So we have the Healthy Leeds plan, and that has a whole set of outcomes that will that commit us to work and the system to working together to address those issues. And it's very detailed, and we're working on it in Development Day the other day. So I'm sure we can bring that back, and he might want to speak about that. But if it wasn't there as an ambition and an intention, we wouldn't be able to point to it and create plans from it. And I suppose that's why we have to keep pushing at that every year. Every time we have to renew it and keep working towards it. And I think we are making progress, but I think it's very difficult when you have headwinds such as COVID and cost of living crises and other issues as well. Thank you.
Okay, thank you. I'm going to take just two more because we've got other items too. So Councillor Hatbrook and then Councillor Berg.
Yeah, just a short observation. I completely agree with what Councillor Taylor was saying around the need to help our most deprived access healthcare, because often they are the ones that do get left behind. I don't think it is easy to kind of draw postcode maps around Leeds just because of the unique geography. And it's one of the things I love about Leeds is that there are very few postcodes that are entirely deprived or entirely wealthy. It's quite diverse. And I'd not welcome us, for example, if you are a poor person living in what is perceived as an affluent and get disadvantaged, that's actually a double blow. to the residents. I'm also just one thing on the GP side of things. I'm in the situation from a personal perspective where, because of family members that I support, I actually interact with GPs from 3 different practices, at least across 3 quite different bits of Leeds. And anecdotally, what I observe is the ease of access, the communication, the proactiveness of those GPs varies quite significantly from practice to practice. And I fully appreciate GPs are their own entity in terms of how they run. But if best practice was spread from the one that my mother has access to others, I think there could be quite a transformation. So, I don't know whether that's league tables or how you go about bringing in that accountability and visibility so that people can see whether their GP in their area is doing some of the things that the more proactive practices are doing.
Thank you, which is still boils down to the inequalities that we're talking about, especially in places as well. Okay, thank you, Councillor Burke. Sorry.
Thank you, Chair. And thank you, Rebecca. It was really interesting to hear your perspective, and I'm sure it's a perspective that we all share. However, playing devil's advocate, resources and the squeeze on resources, particularly around mental health, will impact, I'm sure everybody will agree, on the most ambitious of plans. So, and I've read the plan several times, and it would be amazing if we could achieve everything the royal we. So is there a contingency plan? Because the cost of living impact is rising disproportionately. So the number of people who will be classed as deprived in the truest sense will increase. So that will obviously impact on the delivery of the plans. I just wondered if there were contingency around the resources and funding required.
So if I can respond to three things really. I'm supposed to finish. One is I know we're coming back in March around the ICB, the committee and the development. If I'm really honest, I suspect not much will change in governance terms, and it might be much better we bring the Healthy Leeds plan and the plans for next year back and have a proper look at those. They're the things that are owned and overseen by the Leeds committee of the ICB. So we get into some of actually what it does rather than the sort of governance types questions. So that's just a proposal and suggestion. And I would be very happy to do that. It'd be good to do that. I think then that in terms of GP practice, there is a lot of work being done on variation. And again, I'm sure colleagues at some point will want to talk to us about how we're working with GPs, and we can share some of that, because you're right, the variation is the issue. And we are aware of that. There is a plan. People are working on that. We are trying to share best practice, getting those GPs that understand that. Nevertheless, there are challenges, and that variation is not driven by deprivation. That variation is driven by the individual practices. We've got some outstanding practices in our most deprived areas, and some not so great ones in the more affluent areas. I won't regale you with my anecdotal stories of my practice. I do live in one of the more affluent parts of Leeds. So I think that's a legitimate challenge, and one we are working at, but we may well want to, you may well want to pursue that a little bit more. In terms of the resources and the challenge, local authorities have been through, I've lost track now how many years of unbelievably challenging financial position. The NHS hasn't done as badly, but hasn't done brilliantly. And we are from every bit of observation that we can make at the current position, is we're expecting that to get much worse next year. So the challenges facing us as partners, NHS, local authority, third sector, are not going to get easier when it comes to finances. They are going to get harder. And therefore, the key thing to me is, are we prioritising those resources in the best way? Really challenging in health, because often it is what goes wrong that ends up at your door and you have to deal with it. It's immoral to turn someone away because they don't come from the right background or they aren't from the right place. You are expected to treat them quite rightly. So I wouldn't say there's some sort of contingency. I think we've stretched our contingency as far as possible. The key is going to be getting a plan that balances and is as far as possible sat in line with the local authority plans, and is effectively prioritised to those things that matter most for us in Leeds. It was interesting. You mentioned mental health. At the moment, the biggest challenge for our mental health partners is spending the money because there isn't the workforce. So if we talk about resources, we can talk about money. Probably the bigger challenge that we're most nervous about in the NHS, and indeed colleagues in social care, is the workforce. We can't actually spend the money sometimes, so that is a significant challenge. Or it's very, very expensive because it's agency. So in terms of delivery of our plans, is it money or is it workforce? Well, it's a combination of both. We could have all the money in the world and not have the workforce. Or if we manage to get all the workforce we want, we might be a bit tight on money. Those two together are very, very clearly our biggest risks in our system currently.
Okay, thank you very much to Tim and Rebecca, and obviously Victoria as well, and exec members on that agenda. We can only continue to ask that all the plans and our ambitions, let it be in our deeds and not just in our words. So we look forward to seeing you back in March. So we might not see you until, actually, I think, are you in November's meeting? I don't think. Yeah, there will be some. If we don't see you, thank you for everything and have a Merry Christmas. I'm sure I'm the first to wish you that for this year. So thank you very much. You're free to stay for the other items, but I do know you've got another meeting, but thank you very much for coming. We appreciate it. Okay, we're going straight to agenda item number 8, and that's Leeds Health and Wellbeing Strategy. I believe we've got 2 other officers joining us, and that is Tony Cook and Wasim. Good to see you again, Wasim. I'll allow both of you introduce yourselves.
Thanks, Chair. It's Tony Cook, Chief Officer, Health Partnerships.
Thanks, Chair. Wasim Feroz, Health Partnership Manager in the Leeds Health Partnership team.
Thank you both for joining us. So for this agenda, since 2012, it has been a statutory requirement to have a health and well-being strategy. And with the current strategy in the process of being refreshed, the views of the Scrutiny Board are being sought in terms of the proposed approach and the refreshed priorities as set out in the report within your agenda pack. So I will be asking Wasim now to, is it you to start, or will it be Tim or Councillor Venner?
Yes, you've got a sneak preview of my comments.
Right, over to you then.
Definitely on the right paper now. So, as I have already said, the current strategy was for 2016 to 21, but was extended to 2023. And so we're very much building on the work of the previous strategy in reviewing and developing this new strategy, which continues to be person-centred in terms of well-being, starting with our residents and then being at the heart of everything that we're doing. So the strategy is for everybody who lives and works and visits Leeds, and it sets priorities for partners to address locally to meet the needs of our population, and it sets out the long-term strategic direction of the city with regard to health and well-being. And it's for a broad range of partners in the health and care system, but also beyond the health and care system, because as Victoria pointed out, only 20% of the elements of what contribute to our health and wellbeing are actually within the health system. So our health and wellbeing strategy needs to cover all the wider determinants of health and wellbeing, like housing, green space, for example. And it's set within the context of the Best City ambition, which is, the overall council strategy, the West Yorkshire strategy, which Tim referred to, the Healthy Leeds plan. And of course, it's in the context of the impact of a global pandemic and the cost of living crisis, which I think we would all acknowledge is going to have a potentially catastrophic impact on people's health and well-being. And we know that health inequalities are inextricably linked to poverty, and that more people are going to go into poverty over the next few months. So we're very much in that very sobering context. So this isn't a rewrite of the current strategy. It's more of an evolution in the current context. So much of what's in the current strategy will be in the new one. So it's still our ambition that we want Leeds to be the best city for health and well-being. We want it to be a healthy city and a caring city for people of all ages, so from child-friendly Leeds to age-friendly Leeds. And we are retaining the ambition that's been discussed already about people who are the poorest improving their health the fastest. And I think Rebecca gave a really eloquent description of why that's important and why having that as a written target means that we can hold people to it, and that it kind of focuses our work and crystallizes our thinking around the importance of targeting people who've got the poorest health and wanting that to improve the quickest. So this strategy will be 2030. It will align with the best city ambition, and we still have the 3 pillars, which includes inclusive growth, health and wellbeing, and of course the climate emergency. And Team Leeds is really, really central to the partnership and the way we work together. I think our work as a city through COVID demonstrated that magnificently in terms of the way communities as well as the health and care system came together to help our population through that crisis. And we very much want to have indicators that are both quantitative and about people's lived experience. So I suppose quantitative and qualitative ways of measuring the work that we're doing. I think I'll leave that there and hand over to, actually no, I'll say a bit about, we had a health and wellbeing board meeting a couple of weeks ago where we took the outline approach to them for their feedback on developing the new health and wellbeing strategy. And they did endorse our approach, but had some specific feedback to give us. I think one of their really key messages was, so what? So, well, we've got this new strategy. What does that mean for, people who live and work in Leeds? And they also were really clear that we need to have some clarity and some realism about which priorities are important and what we can actually achieve, recognising that it takes generations to make some of the shifts we want to make. So at the moment, as you know, we've got a 20-year gap in life expectancy between our more affluent and our more deprived areas. And it is not realistic to think we will change that, in a couple of years. That is really, really long-term work. And so the importance of recognising the progress that's already been made, looking at what the priorities are and what we feel we can deliver, in the time frame of this strategy. And they also felt we needed to be really clear about where the health and wellbeing strategy aligns with other strategies. So, for example, we had housing as an agenda item a few months ago because that's so central to people's health and wellbeing. There's also a housing strategy for Leeds, so it's really important we look at how the strategies dovetail, how they're measured together, how they work together effectively, not duplicating work, etc. Okay, so, and then a plan's coming back to the Health and Wellbeing Board in December, so that's how their involvement will continue. And I'll hand over to Councillor Arif to also make some comments. Thank you.
Thank you, Fiona. So from my perspective, just some reflections within my own portfolio of public health and active lifestyle. So our Team Leeds approach has been a key to navigating the challenges of the pandemic and delivering the effective vaccination programme across the city. The physical activity ambition and public health role in health protection, prevention and early intervention will continue to be crucial in improving health outcomes. And whilst progress against tackling health inequalities has been impacted by the pandemic, it's still important to reflect on the successes which have been made in difference and a difference that will be important to build on. For example, the pre-pandemic reduction in child abuse that we had, particularly in our deprived neighbourhoods, the Leeds neighbourhood networks, promoting community participation, social connection and healthy ageing. We had the Lincoln Green Employment and Skills Project. And of course, in my ward and in Beeston, we've got the selective licensing, which is raising the standard of private and rented housing in Beeston and in Hare Hill. So just some of the sort of key things that I wanted to pick out there. At this point, I'll hand over to Tony.
Thank you, and thanks for that introduction. And It's great to be here. Obviously, I took the previous health and wellbeing strategy through scrutiny on a couple of occasions, and in fact, around this table is a lot of people that over various years have had seats on the health and wellbeing board. So there's a lot of knowledge in this room on all sides, I think, which is always great to see. And I think building on the conversation that we've just had about the West Yorkshire architecture and all the changes in the NHS, this, as Councillor Venner mentioned, is very much an evolutionary approach. It's fair to say the Health and Wellbeing Board has had some really strong successes over the last few years. For example, kickstarting a lot of the anchors work with the hospital and the Lincoln Green programme that Councillor Reith has just mentioned. Agreeing a really radical and community-focused mental health strategy, which is really beginning to pay some dividends, I think, for certain community groups. And obviously having that focus on all the wider determinants of health and the challenge of improving the health of the poorest, the fastest. But likewise, there has been, I think it's sometimes difficult to see the progress when we've got all the challenges around cost of living, the budget issues that have been mentioned. But it is fair to say over the last period as well, there has been those successes that I've just mentioned, but also around things like the reduction in smoking, the reduction in childhood obesity that was seen pre-pandemic, and actually the development of a number of new and interesting pilot programs, one of which I'll mention in a bit. So, as I say, it's been very much an evolution. The key pages perhaps are page 24 and 25, which outlines how the 12 existing priorities have changed. So I'm just going to take a couple of quick minutes just to go through some of the key ones there. And some of this has very much come out of the Big Leeds chat that many of you will be familiar with. And one of the key findings from that Big Leeds chat is the concept of being friendly and ever being friendly to each other in communities, whether that's child friendly or age friendly, or indeed the support that people might get with challenges at work is really key. So the first priority is around promoting that friendliness in Leeds, and that builds on some of the work that social care have done about ensuring that social care service users have got at least 3 people they can call on in any crisis. So we're looking to roll that concept out obviously a bit further and citywide as well. We've already heard about the getting more people more active more often, and that remains a huge priority. And linked into that is the need, I think, to improve some of those transport links that have begun to be discussed at a previous health and wellbeing board. The mentally healthy Leeds thing absolutely is a theme that runs through the entire strategy. We're also in the process of reviewing at the moment the mental health strategy. And just quickly, there's been some challenges in that area, obviously in the pandemic and before, particularly around children's mental health. But over the last period, we have reviewed early intervention services for people with anxiety and depression in particular. We've opened Red Kite View, obviously, in Leeds as a children's residential project. And we've got the excellent synergy work, which looks to improve outcomes for Black and minority groups within the mental health system, and particularly the acute system. So the fourth one in the people's category there is the importance of supporting people who care for a relative, neighbour or friend. That's a new priority, and reflecting on all the work in the pandemic, particularly around the community hubs, we felt that was really important to be reflected in this strategy. So we've also got 4 priorities in the draft place section. Obviously, these are all at the moment open for discussion. These are just things that we're landing for engagement, as you know. We feel the 5th one is about reflecting the absolute importance of the diversity of the Leeds community, but connecting those communities to each other and within communities as well, particularly around some of that work on intergenerational factors that we know is increasingly important as we get a significant growth in the population of children and young people, but also at the other end, the challenges that we've rehearsed in this board before about the ageing population and the number of people with long-term conditions. The 6th one covers a lot of the work that we've done around community safety, around health protection, but ultimately how we promote health and wellbeing across Leeds as well. And I think, as we know, how people feel and interact in the neighbourhood is a real indicator of good health. If you feel unsafe, on the ground, it leads to, you know, stresses and strains that can lead to, you know, earlier access to things like residential or domiciliary care. So improving the work that we do with our colleagues in the safer communities world and the community section more generally is really important. And then the one that I think we all agree is something that we need an additional focus on. So we've set up, I think probably a lot of people around the table will know, a breakthrough project to look at how we improve housing and health, and how we really look to improve sort of a lot of the offer that we've got, perhaps things around the private sector accommodation. We've got selective licensing, as Councillor Reif mentioned. We've also had a couple of pilot projects around mental health for people who live in tower blocks that we're looking maybe to reinstate and to try and get funding to scale that up a little bit as well. But ultimately, we know housing is a real indicator of good health. So that'll be one the board focuses on over the foreseeable future. The eighth one is around integration. So the idea with this strategy is that it sits really closely with the Healthy Leeds plan that we've just heard about. And our colleagues in the NHS are obviously doing a huge amount of work on population health, on managing long-term conditions, and on integrating the acute sector into all the work that we do as well. So that'll be a huge priority for Tim, Rebecca, and all our colleagues. And then finally, the productivity ones. Again, these are really, really important, and I think it is important to acknowledge the real challenge that we've got around employment and around cost of living and around some of the inequality indicators. But one of the things that we think we can do, and at the moment we probably don't do as well as we could, is to improve outcomes for people with mental health, learning disabilities and physical health problems. But also as a result of a couple of the papers that have come out last week of the Office for National Statistics, we know that nationally about 500,000 over 50s after COVID have left the workforce. So we know if we're going to get those people back into work, and we know some of the challenges we've got of recruitment in all sectors at the moment, we need to keep our people healthy, but we also need to make sure that we target employment support far more effectively on some of those groups. And it is a challenge, but I think the learning from the pandemic, which we've heard about, is probably gives us a few lessons. So on the learning disability agenda in particular, we took some quite brave decisions to promote the vaccine and open up the vaccine to all people with learning disabilities at an early stage, and that yielded some huge dividends, saved lives, and I think that type of focus is something I think we can do with employment and employment support. So we're talking to colleagues in City Development and the Department for Work and Pensions about how we up our game in that area as well. And then the final three, equally important and linked into inclusive growth, is how we develop skills in the workforce, both in the health sector and more generally. Huge issue to keep our people healthy and to keep the workforce in good shape. The 11th one is something, again, Scrutiny Board has taken papers before about how we work with the universities, about health innovation, and some of the work of the Leeds Academic Health Partnership, which we're bringing in to this conversation as well. And I think importantly, one of the lessons that we've probably got in this area, if you look at particularly London, but also to some degree Manchester, they've had a number of pilot projects that look to develop small and medium enterprises, social enterprises in some of our more challenging areas. And there are lessons about how we might do that and really sort of bring through the talent that we've got across the city in those areas. And then finally, and the idea of the strategy was to bookend friendly at the start and fairer at the end, which came out of a lot of community engagement. And that's around the work on, which I guess is the golden thread running through the first presentation, this one, and in fact the one we've got to follow as well, is how do we get to a fairer Leeds for all? And I think that's the ultimate challenge, and I'll probably leave it there. This is obviously the first conversation we got in Scrutiny, and like Tim and Rebecca, we will be coming back at a later date, I think probably in December and February as well. Thank you, Chair.
Thank you very much, Tony. Yeah, you're due to come back. I believe it's in March, so you're down on the schedule. And just to let you know that every month I do catch up with Tony on updates. And I tell you, even whilst I was on holiday, himself and Steve didn't spare me. I had to zoom in from abroad to join in this update. So I do know how much work they do on this. And it's lovely to see these priorities. Like we said previously, we just need this to be, we need outcomes now. They are great. The strategy looks really, really promising. And we look forward to hearing from yourself, Wasim, in terms of the key highlights of this strategy. Thank you.
Thanks, Chair. I think the only thing that I want to kind of add to what's already been said is I want you to make the point that links to the previous comments in the last item around the equality, diversity and inclusion lens to this as well, particularly in the look and feel of the document, but making it accessible and making sure it reflects the diversity, the rich diversity of our communities across the city. And one of the things I think is really important, which Councillor Venner has really pushed as well and promoted on the Health and Wellbeing Board, is the allyship programme, which links our Health and Wellbeing Board members with community of interest network, third sector colleagues as well. So we're having that constant conversation. We don't just wait for board meetings to happen. Actually, that's that constant conversation with third sector colleagues and third sector leaders to understand the priorities of marginalised communities as well. So I just thought I'd highlight those points because it really links well. And I think the other thing is, and it links to the last item again, is around the West Yorkshire Partnership Strategy. So when we presented it to the Health and Wellbeing Board a few weeks ago, we presented the two together, making sure that actually the conversations around the two are happening together and linking into the Health and Leeds Plan refresh, as well as other strategies that are key to the delivery of those priorities that you've just talked about and tackling health inequalities.
Excellent. Thank you very much, Wasim. Board members, any questions for Tony, Wasim, or exec members? Yes, Councillor Harrington, sorry.
Hi, this one kind of links to the last agenda item as well, in a way. It's a question about how the links work with people being discharged from hospital and the social care aspects that are involved in that and support for them. Because Councillor Anderson and myself have been made aware of a lady she was provided, we think, with an operation in a private hospital on behalf of the NHS, and was then discharged from that hospital very early and shoved back into her own home, but without any care procedures being put in place for that and any treatment. So it's the bit about how do we stop her, because the active lifestyle bit is about how do we stop her ending back up in hospital again because she hasn't had the care that she needs, but also what are the links between a private hospital doing an operation on behalf of the NHS, how do they actually link that to the discharge process so that the social care is linked into that? So it's a question that it has been raised 2 or 3 times, but there has been a very recent case which is quite unsettling, involving a 90-year-old lady. Thank you.
Very good question. Who's answering that?
I can take that one.
Thank you.
I think, there's been a huge amount of work on hospital discharge, but inevitably there's probably a lot more to do. And I think an individual case like that probably needs to be taken back. So I'll have a conversation with Kath as director and Councillor Harrington. I'll either give you a call or ask Kath to do so. But I do think more generally, some of the pathways in and out from my time in the NHS a number of years ago, in and out of the private sector, have always been quite a challenge because the systems haven't traditionally always talked together. I think we've seen some of the challenges. I'm sure Dr. Beale's probably going to jump in on this one about how this works with dentistry as well. So work to do, and hopefully with the new structures that we're seeing in the NHS, it'll be easier to have some of those conversations.
Okay, thank you very much. Victoria.
Yeah, thank you, Chair. And just to add, thanks, Councillor Harrington, for that. And it's not the first time we're hearing these stories, is it? I think there are some patterns here we need to be mindful of. And I think going back to the last conversation with Tim, there is something very real about looking at all of the pressure that the NHS is under and the solutions that are found to manage that, and really thinking about are they having a disproportionate impact on people in a way that actually we wouldn't want that to play out for the people of Leeds. So I think there is something about it goes back to your point, Councillor Taylor, and around access to services of local people. How do we ensure that we maintain the quality and all of that patient experience stuff as we see some of this happening more and more often. So I think there's a role for all of us to play in sort of keeping a watching brief on some of that and supporting our NHS colleagues in listening to the feedback and making sure that that's built into some of the solutions. So yeah, thanks for raising it, and I think that's part of our jobs going forward. Thank you.
Thank you, Victoria. Councillor Taylor and then Dr. Beale.
Just a quick question, Tim. I drew for an application. Now, they just said, for instance, and it's under the NHS. And the NHS referred me to a private hospital to do it, but it's still NHS. Are you telling me there's no communication between both parties? Because if I went on the behalf of the NHS and they are going to discharge me, and while I'm there, shouldn't they not be communicating both sides to know this patient is going home? It's happened in my ward a few weeks ago as well. Where is the communication? And this is where it's locked, because they sent me across.
So I obviously can't answer specific cases, but one thing that the NHS has always done is utilise capacity in the private sector at times of obviously when times are busy, and particularly primary care inevitably will use that capacity in the private sector in Leeds. So yeah, it's just making sure that those pathways are in place and are working effectively, isn't it? And making sure that a clinician in the hospital communicates appropriately with a clinician in primary care. It can be harder in different systems, inevitably, although at times, obviously, it can be difficult in any system when you've got complex clinical pathways.
Nursing is my background, and that's what I used to be in the hospital. So I think the communication just gone out, because in my days back in early 2000, when I was there, it was Bupa days then. And if we refer someone to Bupa, there's always communication between us. And Bupa would not discharge this individual until we at the other end get all the works in place. So are you saying it's stop? There's no of this patient, that's it.
No, I'm not saying that. And I think, oh, yeah, sorry, yeah, no. Yeah, I think it can communication in any system can be challenging at times. And there are things like the friends and families test that obviously everyone does after, an intervention. It's important to use that and to feed back to, to the many people that are responsible for care ultimately. And obviously in the acute sector, there's PALS as well as a service that people can use. So there is that provision there, but I guess it's just to comment that the system is quite stretched and overburdened at the time, which is probably why there's greater use of private sector provision.
Sorry, Tony. Please, you are our representative. There's a lot of elderly, included young, but I'm focusing on the elderly. You don't want them going home on their own in the winter month. It's coming to winter, and please talk to the NHS to do something.
Yeah. And yeah, absolutely, completely agree. Winter is a really critical time for everyone, isn't it? And no one needs an intervention that is perceived to be, not something that helps them. And if people are being discharged too early, obviously it's something that officers here or NHS colleagues can help and support with. There's no question. We'll do our best.
Thank you, Tony. So definitely that will be something that we would need some update on when we come back in March of 2023. But in the meantime, you did promise to get back to Councillor Harrington on that. Yeah, so it'll be really nice to know what's going on there. It's Dr. Beale and then Councillor Hatbrick.
Thanks, Chair. I'd like to pursue what Councillor Harrington started on, looking at the right level of care, but I want to move towards unpaid carers. And one of the things that Councillor Venner has introduced for members of the Health and Wellbeing Board is that we all have an ally from the third sector. It so happens that my ally is Carers Leeds, and I'm an unashamed advocate for unpaid carers. I always have been, but even more so now that I'm sort of involved with that organisation. And I'd just like to pick up item number 4 in the 12 principles, supporting people who care for a relative, neighbour and friend, because going back to the economic crisis, which has been mentioned, and the fact that in the House of Commons yesterday, this week's Chancellor of the Exchequer told us that we can expect worse things than we've got now, I think that we're going to rely more and more on it. I have to say, it goes back to David Cameron's The Big Society, a good idea which never really flourished, never really took off. But I believe that we're going to have to rely more and more in the economic crisis on unpaid carers. And it's very important that we care for the carers, because unless they are cared for, unless they're supported, unless they're given breaks and so on, then the person they're caring for is going to suffer. So I think we've got to look very carefully at how we best care for carers.
Absolutely, Dr. Bill, I couldn't agree more. And from a cultural point of view, I do know my culture and so many other cultures where our elderly people, we do not take them into nursing homes or residential homes. So we care for them in our own homes. So you can see why that priority is really, really important, because no matter how much you care and love, you would need a break, and any support for sometimes the person who's actually given the care is so what's the word in English? Tired, exhausted, and would need a break. So any form of support, I really, really welcome this priority in terms of encouraging people. And obviously, as we're getting into more difficult times, it will be more needed than ever. So I had, is it Councillor Hatbrook? And then I had a hand there, Councillor Venner, and then back to you, Councillor Anderson. Thank you.
Just briefly, I think we can all say amen to what Dr. Beale said, that the carers and unpaid carers in our communities do wonders. And I think, whether it be through COVID or already necessity, I certainly know in my community and around, I see more of that being done. I wish less of it was needed, but it is, and it fulfills a vital role and should be recognised as such. I just wanted to pick up a point, again, from what I've observed with that kind of interface between private, what are mainly primary and what normally are mainly surgical providers and private and the NHS. And I think personally, I think it's down to the fact that it's overly transactionalized, in that contracts are given to the lowest bidder. And, just as, with airlines where all the perks have gone, basically they're on defined contracts to give a defined service, which is a defined operation. And once that is done, they will not do a job more. Now, whether that's resolved by smarter contracting to expect a degree of follow-up and care after that, or whether it's done by going to the lowest bidder to give a defined clinical outcome without the necessary care outcome package wraparound around that, I don't know. But if that wraparound care and that follow-up is necessary, so I think the NHS, in terms of how it commissions with private sector, which it does do when either out of necessity or out of perceived best value, and I say perceived because I'm not always sure it is, it needs to be honest around, actually, we're either commissioning to get the private sector to do some degree of follow-up, or we're very clear that isn't there, and therefore have decisions to make within the NHS and within our clinical provision, what we do to fill that up and factor that into the total life cycle cost.
Councillor Venner.
Thank you. I wanted to follow up Dr. Beale's point about carers. I meet regularly with the Chief Exec of Carers Leeds, and Kath does as well, Kath Ross, separately to me. And it feels really important that we do that, so that we, both of us as kind of senior leaders within the system, get really direct, like first-hand feedback from her about what it's like for carers on the ground. And it's really helpful because she'll give us that very frontline grassroots experience. And we are really aware that carers are being asked to do more. So for example, when people are getting ready for discharge from hospital, you know, carers being asked if they can manage, and very often saying yes, even if they might actually really struggles. And we're wanting to be really mindful and really on top of that. And obviously we fund carers Leeds, but also making sure things like carers assessments are done really promptly, that people have access to respite if they need it. And we have a carer strategy for Leeds, which has the title of Carers at the Heart of Everything We Do, which was very much what kind of carers Leeds and carers wanted to be our approach. And of course, we have a lot of young carers in Leeds as well. We have a lot of children who are carers, who are also supported by specific services. But I just wanted to give assurance to the board, really, that both Kath and I are really aware of the pressure on carers, and that's why we've set up this very direct, regular contact with carers Leeds, so that we can hear firsthand how it is for people and try and ameliorate the pressure that people are under. Thank you.
Thank you. That's very comforting to know, Councillor Venner. Thank you. Councillor Anderson.
Thank you, Chair. At our, we had a subcommittee meeting this morning of the health subgroup of our Outer Northwest Community Committee, and we heard from Tim, I've forgotten his surname, who might have been, specialises in dementia within adult social care here. And he was telling us, even in our area, there are 12% of the people with dementia in our area living with severe dementia, and of those 50% are still living at home, which is, in one way, it's great because they're not in a nursing home and they're being cared for by a spouse or a partner. But they must be under so much pressure. And I know during the pandemic we've got at least 3 friends who were looking after their husbands or wives with severe dementia during the pandemic, and I just cannot fathom how they'd got through it, really. But I think, they do an absolutely wonderful job. Unpaid care is fantastic. And I always refer people to Carers Leeds just for support and to see what is available for them, because a lot of the time people don't actually know what's out there till they find themselves in that situation, and they don't know anybody else in that situation. They need to know what's available. So we need to stress all the time, promote things, make sure people are aware. And I think that's really important.
Thank you very much, Councillor Anderson. Yes, Councillor Benner.
Yeah, I just wanted to come back on that really specific point about people not knowing what's out there. I think this board might remember when we brought the monitoring from the adult social care outcomes framework, the ASCOF measures, a couple of months ago. We noted that satisfaction levels had gone down for both people in receipt of service and carers. And at the time, we didn't have data for other authorities to just compare whether this was a national issue, because actually it was looking back over the last year, and I don't think anyone's satisfaction with their life over the last year would have gone up, really, given what we were living through. But we did really focus on the care aspect of that, and whether people know what support is out there. And Kath did actually take an action away about committing to making sure that we write out to carers and remind them what is there, because I think when you're very immersed in caring, you need that information given to you really directly and easily and accessibly, because it's hard to look for it yourself. So we have absolutely picked that up as a specific action from the ASCOF monitoring. Thank you.
Thank you very much, Councillor Venner. Okay. Any additional question on that item? Otherwise, okay.
Just a small point.
Yeah.
I suspect a lot of people that are carers might not recognise themselves as carers. I think that actually signposting people to the fact you are a carer, because again, I've experienced that from in my own kind of family situation, where whether it be either being registered at the GP as a carer or actually thinking of themselves as a carer rather than just doing what any family member would do. There is, because often it's not a step change, often it's a gradation, especially with things like dementia, where sometimes it just creeps up on you. And I think that I don't know what the answer is again to basically getting people onto that thing, to actually over the hurdle where they say, actually, you are now doing this, and here are some resources that, as this progresses and you go on this journey with your loved one, you can, gain access to an increasing and appropriate level to the resources that are out there. And it's difficult from a signposting point of view, because it's not binary. It's not a switch where somebody goes from not being a carer into a carer. Often it's a slope.
Thank you. Yes, Councillor Van, just to add to this, do we have a mechanism where people who care for people actually let us know that they're carers?
Well, within the Care Act, people should have a carers assessment, but obviously they need to flag up somewhere, which could be through the GP, could be through a hospital. But under the Care Act, carers are entitled to a carers assessment of their needs. The point I wanted to make in response to you was actually, as I meant to make this point earlier, Chair, in response to something you said, but I was referring to the point about people not necessarily identifying as carers. I spoke at an event earlier this year that was about dementia in BAME communities. Most people there were specifically from Black minority groups. And that the point you made earlier, Chair, came across really clearly about people want to care for their relatives at home and for them not to go into care homes. So the absolute importance of making sure carers have support. But there was also a theme about people not identifying as carers. So, well, it's my mum, it's my partner, just not necessarily recognising that label of carer. It's just what you do if you've got a partner or a family member who needs care. So I think that makes it, it was identified in the event that that's an additional potential barrier to people getting support if they don't identify as a carer, and that's more prominent in some groups. Thank you.
Thank you very much. Wasim, Tony, is there anything you would like to add to this before we move on to the next agenda?
And just to say thanks for all the comments. We'll absolutely take them on board. And I think just quickly on the carers issue, that carers was not in the previous strategy. It's something that is entirely new, and that absolutely reflects the need for visibility and the importance of the agenda. So when we do the communications and engagement over the next few months, obviously that's something we will have an absolute focus on, which will be encouraging people to understand whether they are a carer and the role that carers play as well. I mean, I think probably everyone in the room is probably caring for someone either younger or older. So yeah, absolutely, it's something that needs that prominence, but also in the communications around the strategy as well.
Thank you very much. So we will continue to have a watching brief on that, and obviously you're coming back to ourselves in March of 2023. So it would be really good to just to have an update on the refreshed health and wellbeing strategy prior to our meeting in March of 2023. So thank you very much again. I think you're still going to be there for the next agenda, maybe just Wasim. Wasim, you're free to stay if you would like to, but yeah, that's fine. Tony, I know you're down for the next agenda. Okay, so the number 9 will be Mammoth City progress update. We all know that this is the Mammoth City proposal was something this board really welcomed. I'm personally very proud of it, and where we are so far. So it will be brilliant to hear from yourselves on what you have been doing so far, and all the existing commitments across all partners to reduce health inequalities and improve the health of the poorest the fastest. I do know Councillor Taylor says she doesn't like that word of the poorest and the fastest, but yeah, there you go, it's down there. So we would need an update in terms of the progress for this work, and obviously we would also love to know your next steps. I believe we have Tim here, right? You're welcome. It will be nice for you to introduce yourself, please.
Is that right? Thank you very much, Chair, and great to be here. So it's Tim Fielding. I'm Deputy Director of Public Health. So I started relatively recently with the council back in July. So yeah, pleasure to be here.
Thank you for coming. Okay, I believe, is it Councillor Arif? Are you going first?
Yes, Chair, that's me. So
over to you.
Pleased to bring this Marmot City progress report back to the board, particularly on the back of the conversations Councillor Taylor invoked on about health inequalities. So lots of progress has been made since January, including recruitment to some key public posts that will contribute to the Marmot City work, including our Deputy Director of Public Health, Tim, and also the Head of Public Health. We've been developing the approach based on the feedback from Scrutiny and other key forums, including identifying the best start and housing as two of the key priorities for Leeds. We've been ensuring understanding, support and buy-in across the system. We know from the other Marmot cities that strategic commitments, partnerships and relationships are key to the success. We've been working with the Leeds for the 3 best city ambition pillars to embed the Marmot City approach in the refreshed strategies currently being drafted, and also embedding the principles and approaches in a wide range of work that the officers will talk about. It's also important to appreciate that it's still very early days, and we have not yet formally agreed or launched the approach with the National Marmot team. Councillor Renner, senior officers and I are meeting with the Marmot team at the beginning of November to discuss and confirm the approach and timescales. It's also important to recognise that becoming a Marmot City is not going to lead to lots of completely new projects and interventions. Unfortunately, there's no additional Marmot funding stream, and everybody around this table will be aware of the financial challenges that the city faces. But what we will do is help us go further and faster, improving the health of the poorest and the fastest is detailed in section 19. And some of the work that we'll be doing is building on the approach that we've taken in Leeds so far on inequality. So we're going to amplify work already happening and going faster and quicker. We're going to use by using the evidence to identify gaps and opportunities, influencing resource allocation where appropriate, and working with colleagues across the council, ensuring that inequalities is everybody's business. While wanting to push on the work and make a difference fairly quickly, it's also important that we do it in the right way and we don't rush anything, that we ensure that the approach taken is absolutely right for Leeds, which is being done currently. I look forward to the contributions from the board and the discussions that come from this conversation. But for now, I'll hand over to Tim.
Thank you, Councillor Arif. Over to you, Tim.
Thank you, Councillor Arif, and thanks, Chair. I'll assume people have read the report and hopefully can see some of that progress we made, and some of which has been covered there through Councillor Arif. All of this work over this last year in developing the Marmot City work has led to significant impact already across a range of areas in terms of really informing and shaping a range of work. So even though the formal stage, if you like, of the Marmot City work hasn't yet commenced and will follow on from that more formal agreement with the Institute of Health Equity, and we anticipate that would start and kick in early next year, it has still had a significant bearing on shaping across a wide range of the work following on from this last year. So some of the particular areas I wanted to highlight were areas like housing, some of these really key building blocks of our health and our own health and communities. So public health, housing and health partnerships colleagues have been working really closely across the council, linked to some of the work that Tony's already mentioned, for example, through the Breakthrough project, really ensuring that there is a Marmot approach taken right the way through that work, through the Breakthrough project, aligned with that best city ambition. So some of the early sort of examples that have come from that, we're doing a piece of work at the moment, evaluating ourselves and self-assessing ourselves right across all of the range of Marmot recommendations that have come out from existing Marmot reports, including some specifically on housing. That's going to give us a really valuable baseline and shine really key light early, even before we started the formal work. Tony's already mentioned some of the other areas like the selective licensing and the continuing rollout of that work, looking at some of the further extension potentially of the Rise High work and some of the wider partnership work that we're doing. And again, absolutely ensuring that we do that in a really dovetail way through the Marmot approach with those existing areas to ensure that they absolutely do add as much value as possible to right the way across the population. As Councillor Arif has already said, the Marmot approach isn't going to be something that is completely new and sits entirely separate from existing work. It's one of the key principles that's highlighted in the report is about that strategic alignment. It will be about working in really close alignment with those existing structures, with those existing colleagues, with those existing strategies, particularly those big 3 of the best city ambition ambition and also the Healthy Leeds plan to make sure we are as effective as possible in relation to the health inequalities within them. Another key area is around cost of living, obviously very acute. The timeframes, as the report highlights, are that we'll be working across the short, medium and longer term, which is critical when we're looking at some of these health inequalities. But actually, we do need to be really clear about those very short-term pressures that people are facing right now. And so, obviously, ourselves working really closely with other colleagues around those immediate cost of living issues. We're also working really closely, thinking a bit further ahead around the inclusive growth and employment issues as well. So building again on some of the work that's already been referred to, working really closely. Some of the examples there are pieces of work, for example, that we're in the process of planning jointly with Health Partnerships team and inclusive growth colleagues around really understanding and researching what is underneath the current trends and current economic inactivity that we're seeing. So why is it that we see the trends? We know that there's new trends, if you like, in economic inactivity, which are driving some of those inequalities, really getting under the skin and understanding those in our communities in Leeds. Also building on some of the work that we've got funded currently, 3-year funding with Health Foundation, building on the work that's been done with anchor institutions, but taking that into the private sector around business anchors and really trying to strengthen the role of the business sector, private sector, and links with public sector anchor institutions and the community as well. And then finally, just to mention the Best Start area. So the Best Start's another area that's been highlighted as one of the key priorities. We do have a Best Start plan and with an action plan that goes with that. And there's going to be work as identified in the report that will really be one of the key areas that we take forward. But again, really to try and assure the committee that actually significant work is already being done in anticipation of that piece of work, preparing the health needs assessments, undertaking the evaluation of what the impact of the current plan's been, but also really shaping existing work with that Marmot approach about recognising all those principles of the Marmot approach in work that's happening, for example, around childhood vaccinations, and also the sort of recovery from COVID in relation to children. So really just happy to take any questions, answer anything, and very, very happy and would expect to get the opportunity to come back hopefully early next year once we've got that clarity, the sort of formal timescales and processes with the Institute to give that next update about where we are and how we're taking that forward for them. Thank you.
Sure. Thank you very much, Tim. Now over to board members. Councillor Gibson.
Thank you, Chair. I was really excited actually when I first heard about this project. I think it's wonderful and it was great when it came to full council. So I'm really glad to see that it's progressing. I'm disappointed to hear that there's no money specifically allocated to it. But I mean, you know, in the times that we're in the 12 years of cuts and things are set to go to worse, I suppose that's not surprising. But my first question relates to funding directly. Is there an acknowledgement from central government about the benefits of this approach? And is there any support from central government and including money for taking this sort of approach? Or is it very much just, you know, as a local authority and maybe regionally, we've just decided that it's something that we want to move forward with?
Yes, Victoria.
Do you want me to start?
Yes, please.
So, yeah, I mean, as we all know, there is no new money for anything at the moment. So I think it feels absolutely the right thing to do, but we have to be kind of extra bold and creative about how we're going to create the resources to do it. So the fact that we've been able to carve out some, you know, part of Tim's role and then create some other parts of roles within the Public Health Department and with other partners means that we've just been really creative and have potentially challenged ourselves to stop doing stuff that isn't as important as this. So there is no new money, there is no kind of regional pot or national pot we can tap into for this, but we've taken the decision locally to make that happen. I think the answer to the central support is no. This is a it's a national movement. It's really interesting that it's becoming a national movement of places saying we want to do this as a place because we're actually not getting this coming down nationally. So it's very, very local. Councillor Gibson.
Does anybody else want to comment? You all had your hands up. But
Yeah, thanks for that, Victoria. So to answer your question in relation to the government's priority, actually, I think it was only last week, the three of us, Councillor Venner, the leader of the council, James Lewis, we wrote to the Secretary of State for Health and Social, because there's actually reports that they're not going to publish the white paper on health inequality, which is, you know, it's ridiculous to be quite frank, and actually shows the commitment in terms of funding. Actually, public health in Leeds, I don't know if you're aware, we get, compared to the rest of the core cities, one of the lowest grant funding. I believe we get £59 per head. I think Manchester compares at £108. So that tells you the level of money that we have got. But I think Leeds does recognise that this work is really important. We recognise that the pandemic did highlight health inequalities, and there were certain areas where, you know, health inequalities certainly were greater. Councillor, the chair gave a really sober statistic earlier. Another sober statistic is that women in Leeds Dock have the lowest life expectancy in the whole of the country. So I think it's those sort of statistics where we as leaders for the council have got to think about what can we do and how can we commit to this work, because it's really, really important. But we've got to sort of do it in the constraints that we're up against, Councillor Gibson, and we're trying to, and we've got Tim in place and we've got that commitment, we're carving that out. But I think we've got to amplify some of the work that we're talking about, and I think we've got to be creative. And housing is definitely something that is really important. Just to give you an example, when we talk about wider determinants of health, I was out with some colleagues from selective licensing in Hare Hills literally last week, and we knocked on the door, and you know, she's got 4 children, and one of the children is suffering from, I imagine casework wise we all get this, is breathing difficulties, and because they had damp in the house, but we were able to go as officers, and we're going to have conversations with that landlord about the quality of that housing. So I think those are the sort of things that we need to look at in the wider determinants of health, and that's why this work is so important. And then I'm really, really happy that the council is, you know, pushing forward with this work. But it's not going to be easy, and we just have to be really creative and amplify some of the really good work that's happening.
Thank you very much, Victoria, and Councillor Ari, for that. Obviously, it breaks my heart to know that for such a brilliant proposal as this, which all of us on this board, you know, welcomed, and we're looking forward to seeing it happen. And we know that for some certain things to be successful, you need good funding. So obviously, Victoria, you did say there's no new money. Is there any old money?
Well, I mean, that's the approach we're having to take to sort of recycle and reprioritise the resources we already have. So, for example, you know, all of our public health teams are re-looking at the work programmes with a marmot focus and saying, actually, how do we bring this to all of the work we do, rather than it being, like Tim was saying, rather than it being a separate project. It's something about challenging everybody in their day-to-day work. So we're having to work within those circumstances, Chair.
Okay, so Tim, then Councillor Hatbrook and Councillor Gibson.
Thank you, Chair. Yeah, just 3 things really, I suppose, very quickly. I wanted just to add to those points already made by Victoria and Councillor Arif. I mean, there isn't any money. There's no getting around. I'm not going to change that. But I would say 3 things. One is it's about trying to raise the bar further on the effectiveness of the things that we do collectively, particularly as a council, but also as a system and a city and a group of partners. And so that's about getting even greater bang for a buck of the existing money that we do get. And so the approach hopefully will do that. The second thing is about being able to operate more efficiently across a wider range and drawing and attract resource in kind, and be able to be in a better place position, because actually we have that even stronger narrative. Leeds has a really strong narrative about addressing inequalities, but this is about going even further and raising the bar for that will mean we can draw and we can make better use of collective resources more efficiently. And the third thing was, I was really struck when going back recently and reading some of the original Marmot report that was published in 2010. And one of the key headlines from that was making the point that that was written in a point of adverse economic climate. And it was written coming off the back of the 2008 economic challenges. And it was really highlighting that actually that just really strengthened the need for taking that approach for addressing those inequalities at that point and seizing that opportunity, even in those constrained financial times. And I guess that just feels like it really resonates now in terms of where we are as well. Thank you.
I think actually Councillor Gibson was itching to come in before me, but I'll make a quick point. I was just picking up, I mean, the old money, new money discussion. I just want to pick up on something Councillor Harris said around the level of the disparity between funding per capita between Manchester and Leeds. I was slightly taken aback when you said it, to be honest. Is there some simple explanation, or is there, and more importantly, is there anything that we as a city can do to bridge that gap?
Yeah, so the simple explanation is that when public health came over to local authorities in 2013, we brought with us the budget that was in place for public health for each local authority area. So previously to 2013, public health as part of the NHS were commissioned by what was then the version of the CCG that was a health authority or a PCT or whatever it was then. So it was a health commissioning decision about how much to invest in public health in every single place. So we had a view on that in Leeds, and that was the position we brought with us to the council. Since then, there's been some kind of benchmarking done nationally with this is what areas should be funded per head of population. Can you please try and get up to that? So we know we're in Leeds, we're about 12 to 14 millions below the level really of the benchmark, not the level of the best, but the level of the benchmark. And we you know, that because of since 2013, cuts that have had to be made every year, we've never managed to improve that position but it's based on the decisions of our health commissioning colleagues previously. Now, often areas that have very large teaching hospital trusts have relatively lower public health budgets because it's only what you know, so there is an impact of there's only so much money and there has to be decisions made about how to spend that across the healthcare system, and we were part of that healthcare system. So it's very much a legacy of those decisions that were made in Leeds by NHS decision makers of the day that we now have got to make the best of that and continue. What I will say on a more positive basis is that on top of the £59 per head, because of that relatively low position, we do have proportionally quite a lot of additional funding that comes in now from Tim, who has just been sitting there, almost to try and compensate for the low starting point. So we've got quite a lot of additional bits of money, but again, that's not recurrent long-term grant. It's often short-term money for particular things. So not to say NHS colleagues aren't very helpful, because obviously this is all before Tim's day, but it really is trying to redress that balance and no, you know, but there's not an obvious place to get that funding from.
Yes, Tony.
Yeah, and just to echo that point, we've been quite successful in bidding for that sort of funding money as it's known. So a lot of the work around the employment advice in primary care that I mentioned, which we're hoping to scale up, basically was funded from some money from I can never remember, it's the department that is now called Levelling Up, basically. So we got some short-term money there, which was quite successful. We've also got some money from the Health Foundation for a project called Good Jobs, Better Health, Fairer Futures, which funds a lot of the work in and around community anchors. And I think is probably quite well known. We've 2 weeks ago submitted a bid to Department for Work and Pensions for around £2 million, and the intention is to to scale up that work in GP surgeries around targeting people with learning disability and mental health into work. And if we get that 2 million, the idea is that we can support 1,000 people into work over a 2-year period. So we're doing our best to bring in other resources that can really bolster the Marmot work and the wider work on health and well-being. And ultimately, we've been relatively successful, but we suspect that probably will be a way forward in terms of accessing the sort of maybe non-traditional resource that we've not always applied for in the past.
Okay, thank you. I'll need to say something, but Councillor Gibson.
Follow-up question for my first question, Chair. I think the reason that Marmot City stuff is so good is because it's packaged really well, isn't it? It's easy to understand, it's easy to get your head around. So from a comms perspective, it's fantastic. And I've noticed, you know, when I'm talking to my constituents about it, you know, it's easy to win the hearts and minds and get people to buy into it. So yeah, of course, everything requires money, but it's not, you know, it's not absolutely fundamentally reliant on money to make this work. So I've still got hope and still feel very positive about the whole project. Having said all that about comms, it seems to me that you know, that it is, because it is easy to win the hearts and minds of and get people to buy into things. If there was an area of Leeds, say, that was building 5,000 houses, football pitches, and a new shopping centre and a new retail park and things like that, that would be a good area to sort of try and bring people in to sort of pilot this. I don't know what your thoughts are.
Don't you love Councillor Gibson's dream? Who's answering?
Okay. Yeah, Councillor, we haven't met. I believe you'll be referring to developments happening in East Leeds. I think it's fair to say. Yeah, I mean, I think you know, I'm a big fan. I suppose two different, one of which is the Marmot approach in health inequalities. It's at the core of what we do, that sense of the wider determinants, the social impact of where we live influencing our obviously our health outcomes, and really shining a light on that social gradient that happens right the way across, not just in the most deprived versus the least deprived, but actually all the way through community, and the importance of the fact of how we address that, and the continuing impact through people's lives. So I'm really keen with that, and also around spatial planning and the impact that can have, again, in terms of building those really valuable building blocks and the impact that can have. So I think I completely, you know, agree and welcome it. I am involved in some regional work around spatial planning and building of healthy places, how we can bring those two in a line. And there's some fantastic work happening through colleagues in public health, working with planning colleagues around influencing the planning system, introducing health impact assessments, and influencing planners at the earlier stages. So really keen to look at the opportunities that we can bring those principles of Marmot into to influencing the thinking across the board. That for me is the sort of vision of how it should go, seeping in across everything.
Been really cheeky there, Chair, and I apologise to the board, but you know, I wouldn't be doing my job properly if I didn't ask a question.
It's all right. Okay. Councillor Taylor, and then Councillor, is it Berg? Was it you? Did you want to say something? After Councillor Taylor.
Yeah, I welcome this, and I'm really pleased, because who knows me know that I'm all about health inequality and deprived area. I do understand about the money. There's nothing you can do about it. It's been robbed from us, and you're working with what you have, and thank you for that. But my colleague mentioned planning, which I was going to mention. I'm chair of planning, but you need to work more closely with planning, where we put in these fast food shop, and you have started at the right place in schools, because kids educate parents. And Leeds have different languages, and some parents don't understand, but the kids will help to improve. So yes, I do welcome it, and I'm really pleased for it. And I was impressed when Councillor Arif says you've been to houses. This is where you go to the deprived area, and this is what I want to see. At least you take it to them, but you can't make them do it. So thank you for that, Councillor Arif. And I'd like to spread it out across the city, just to pop in every so often. Thank you.
Thank you, Councillor Bray.
Thank you. I too welcome Marmot. I think it's a fantastic policy approach. Two questions really. One, I spent some time reading the Manchester Midway Review, which throws up some quite interesting insights, doesn't it, into progress made. So based on that, the one thing that's, I nearly said missing, but I mean not present, obviously, is the measurement and evaluation tools that we would use to look at progress made. Distance travelled is probably a better thing to say. And that was one of the things that was really prevalent in the Manchester report. And I'm saying Manchester because they've been at it quite a while, haven't they? So they've kind of learned some lessons from it. And the other thing for me is that, and like you said, it overlaps, it's kind of a holistic approach to the policies. So two things. One, measurement and evaluation, which I think is key to next steps, isn't it? So it will continue to become embedded. And how do you aim to embed all the 6 principles of the Marmot City, which are huge principles, aren't there? Particularly where we have limited control beyond the authority. Very limited control beyond the authority. We could have influence, but no control. How do you envisage embedding them across the city outside the realms of the local authority? Because I think that's important. Thank you.
Yeah, thank you. I mean, 2 fantastic questions. I'll take them in the order you asked. Measurement, hugely important. You know, one of the things that really highlighted in the report, one of the real values that can come from this is about that that really clear-sighted view of what is happening in relation to inequalities, both across the city, but also in relation to specific strategies and decisions. For me, the real sort of ethos of the Marmot City work is having that impact on inequalities and impacts across that social gradient at the heart of every decision that we make, and understanding and knowing what impact that is having across that breadth of that population. And in order to do that, you have to have a really clear view on the data, and you have to understand what impact that's making. So the monitoring and the measuring will be absolutely central to that. So there's a couple of sort of early things. One of the things is about firstly starting with that principle of strategic alignment and not trying to jump in by inventing whole new structures and bureaucracies where things are already happening. So there's a number of mechanisms already, either in train or in development, that we're already working with and trying to look at alliance. So some of them come here. There's the public health performance reporting that comes to us here. That has a really strong focus, obviously, already around inequalities, but there'll be an opportunity there to review that, to look and see how fit for purpose that is around the whole development and evolution of this new agenda. Other areas are obviously the broad joint strategic assessment that there already is. As you'd well imagine, working really closely with colleagues like Tony, like Sam Foy and others in the policy teams who work on developing those, and in our public health intelligence team, to look at how we can work closely, align and ensure they're fit for purpose around the Marmot agenda. And then 2 others I'll just mention. One is, again, working with those same colleagues on the development of the dashboard and the performance framework around the best city ambition to as far as possible ensure that serves this purpose. And the other is the work that's been done, and I think is predominantly coming through the inclusive growth area around the social progress index, which has huge potential, I think, in this area, and is an area we've already started looking at and seeing how we can combine. So there's some of the strands that we're looking at already, but it's going to be one of the areas we're also really keen to learn what other areas have done and pick up with the Institute of Health Equity when we talk to them. But yeah, and applying that to individual decisions and projects that we're taking forward as well, to be able to really have that rigor and discipline. The second point about the 6 principles and taking it out wider. So this is where we have to get some balance and measure about biting off manageable bits and getting carried away with trying to do the whole thing and trying to get the appropriate balance between the 2. Obviously, the full scale of the Marmot approach is vast. It covers all of those conditions in which we live, grow up, work around the city, and right across the people's lives, as is reflected by the original 6 and now the 8 principles of the Marmot approach. So I think we do need to have the appropriate level of ambition about the fact we are working across all of those, and the fact that this isn't a council initiative, this is a city initiative and programme we take that does need to pull in and apply across breadth of care, health and care systems, but also third sector and business and all sectors to have a kind of coherence and be pushing in the same direction. But we do need to balance that by actually recognising that if we try and do too much too soon, too fast, we'll potentially not achieve what we want. So hence having, you know, the value of those priority areas already been identified, the best start in the housing namely. So one of my roles, I see it, is going to be trying to balance that, and we'll pick that up, I think, in the conversations with the IHE and formalising what that whole approach looks like, about how we do get that balance over the programme, about working across the breadth, working across the sectors, but also being focused enough within the resources we've got that we can actually make real gains and strides forward. So hopefully I'll be able to come back with got some early thoughts around that, but hopefully come back with a much clearer view on that when we come back and give the next update. That's okay.
Thank you very much, Team. Victoria.
So Tim said it almost all there, and I agree on the question about how do we know if we're making a difference. I think that one of the reasons why we did this is because we were tracking all of the indicators in the 6 months report we bring here, and they weren't going in the right direction. We all know that they were either stalling or going in the wrong direction. So I don't think it's that we need to set up a load of different processes to measure how it's going. We need to look at the stuff we look at anyway, and actually, you know, see if it's making a difference. So I think that's the general approach on that, Councillor Burke. I think that your second comment is really interesting and kind of goes to the heart of this, because I think what we've decided to do as a city, and it's interesting with Councillor Gibson's comments as well, is this, you know, if you look at the 8 key principles, they are so big and bold and broad. And you're right, you know, some of this we you know, in terms of principle 7, tackle discrimination, racism and their outcomes. We don't control all of that, but we absolutely are committed to doing everything we can across all 8. So there was this thing about, as we came through the pandemic, after 10 years of seeing inequality stall and actually seeing health outcomes and inequalities take a huge hit from the pandemic, knowing that we had to be incredibly bold because we couldn't carry all of the great things we were doing, we needed to continue to do, but it still wasn't enough. They were still moving in the wrong direction. So this is massively ambitious. We've got to be really brave and bold, haven't we? And we won't achieve, you know, all of this at once, as Tim said. But I guess that what Marmot gives us is that hope, like the hope that actually there are this is a solvable problem. There are things that we know we can do. It's just that collective kind of will to want to do it. So I think that it's so heartening to hear people's comments today, but I think we're going to need all of us to be ambassadors for all of this, and I think that being here in the council is absolutely the place where you get all of this stuff. But continuing that message around actually the building blocks of good health, that 80% are all down to these 8 things, and actually we actually can influence and shape probably more if we think than that. So it is ambitious, and you know, but let's see where we are in a couple of years. But I think if we don't do this, we're kind of accepting that we're going in the wrong direction.
Absolutely, Victoria. Couldn't agree more. And thank you very much. Just one last question from me. The agenda pack, page 47, number 23, you do have down that you've made no formal or informal consultation with Leeds residents. Is there a reason why?
Yeah, so I'm just sorry, bear with me. Yeah, so there isn't, as far as I'm aware, that's happened as yet. The engagement, I think, is largely being done, as it says in point 24, in terms of representative bodies. So in some of the, well, most of this precedes me coming in, so others might want to come in, but I think there's been a wide amount of consultation, engagement and discussion that's been done through a wide range of boards and forums, including this one, but also Health and Wellbeing Board and other representative boards that have obviously included a wide range of representatives, which I think and others might want to comment, probably felt appropriate given the nature of the decisions taken at the time. But I think as this goes on, one of the things that is also included in there is about that principle of needing to ensure that there's a real focus on this, on the people at the heart of it, as has already been mentioned several times this afternoon, and that this doesn't become as an approach detached from the people at the heart of it, and that we are working with and doing with and not to. So really thinking about how we do that. I don't think we know quite yet until the approach is fully shaped what and how that looks like. So I think one of the things we've just tried to do at the minute is really highlight that as a key principle and a key value at the heart of the way we want this approach to evolve, to make sure that we've got it down as a marker as it evolves, that we need to do that. But I don't know if anyone else wants.
No, that's fine. I like the word yet. So for me, one of my attraction to the proposal was it was very people-centered and people-focused. So it will just be good to know that, you know, the consultation at some point is in the picture. Thank you, Councillor Arif.
Chair, if I may come in, the idea also is to get involved the health champions across the city. So this is going to go to the health champions meeting, but also our community committees for their feedback as well. I think that'll be really important. So it's sort of still early days, work in progress, but yeah, really valid point that you made there.
Thank you very much. Okay. You'll be pleased to know that we've come to the end of that agenda. Okay, so thank you very much to all the contributors and exec members for all your, and of course, board members for all your contributions. We're now agenda item number 10 and over to you, Rob.
Yes, thank you, Chair. This is the latest version of the board's work schedule for the current municipal year. Also attached as Appendix 2 are the latest executive board minutes from September, as well as the West Yorkshire Joint Health Overview and Scrutiny Committee minutes, draft minutes. I think important points to note, some of which have been discussed in the pre-meeting, is the now scheduled new meeting on the 8th of November, which at 2 o'clock, which constitutes the board's next meeting. So that is to consider dentistry and issues that the board have discussed previously. Then on the 22nd of November meeting, which is the one after that, there is a new item on the work programme, which relates to winter planning and then resilience within the health and care system in Leeds, which I think came from a discussion at the September meeting of the board. Budgetary work, as some of you will know, takes place annually. There has been a slight adjustment to that following discussion with finance colleagues. So the working group will now be in December as opposed to November, and that reflects the timescales for the proposals coming through from colleagues in finance. An exact date on that is as yet to be determined, but I will obviously, or Angela, my colleague, will keep you informed as soon as possible. And then lastly, I think there are a couple of items from today's meeting that perhaps need to be worked into the work programme with you, Chair, when the opportunity arises. Items 8 and 9 in particular, I think will be returning this year. Thank you very much.
Thank you very much, Rob. And just to say a huge thank you to each and every one of you, board members, executive members, officers, our Leeds students. Are they still here? Oh, well done. I hope we've been able to be helpful in your public policy module, and hopefully we get to see you again. So thank you very much for coming. Is your lecturer still here? Oh, you're there, right. Thank you very much. Can you look after them for us, please? Yeah, excellent. So thank you all so much for coming. And of course, our next meeting is 8th of November.